Hello, and welcome to this HCP Live peer exchange on the treatment landscape for the management of ADHD, Attention Deficit Hyperactivity Disorder. I'm Dr. Teresa Cerulli from Beth Israel Deaconess Medical Center in Boston, and I'm excited to announce that joining me today in this discussion are four of my esteemed colleagues and ADHD experts. Dr. Ann Childress from the Center for Psychiatry and Behavioral Medicine in Las Vegas, Dr. Andrew Cutler from SUNY Upstate Medical University, Lakewood Ranch, Florida. We also have Dr. David Goodman from Johns Hopkins University School of Medicine. And finally, please welcome Dr. Timothy Willens from Massachusetts General Hospital here in Boston. Our discussion today will focus on the current available therapeutic options to treat adult ADHD, as well as newer agents in the pipeline with novel mechanisms of action. Let's get started. David, it would be great if you could get our group rolling. Tell us, what is ADHD, and is it different from ADD?
Well, ADHD is the formal diagnosis. Without hyperactivity and impulsivity in adults, the general public will call that ADD, but ADHD is the formal diagnosis. And then it breaks out into three flavors, I like to call them. You have the inattentive, you have the hyperactive impulsive, and then you have the combined type. What's interesting from the DSM-4 to the DSM-5 is we've gone from subtypes to presentations. And that's because the children who might have had hyperactivity and impulsivity and would have been a combined type as a child may now be an adult with less hyperactivity and impulsivity, so that they don't reach the symptom threshold for a combined type, and they get diagnosed as inattentive. So we now go on presentation of presenting symptoms when you see the patient for a comprehensive psychiatric evaluation.
And those presenting symptoms now are a little bit different, right, for adults in terms of diagnostic criteria from changing from the DSM-4 to the DSM-5?
Well, there are several changes now. The DSM-4 had a threshold of age 7. We've increased that to age 12 because a lot of the inattentive children weren't being diagnosed. A lot of the focus was on the disruptive behavior. However, as the children age, the inattention and disorganization become the source of the impairment along with executive function. And so the evolution from childhood to adulthood, and then my area of expertise now is in older adults, looking at the trajectory of these symptoms over the course of time. But coming back to the DSM-5, you have the symptoms, and the symptom threshold has changed for children and adults. For children, it's 6 out of 9 inattention or 6 out of 9 hyperactive impulsive symptoms, while for adults, it's 5 out of 9 in either of the two categories. So you have the symptoms, you have the impairments that they need to cause, because you can interview somebody who says, I have occasional inattention and distractibility. It doesn't mean you have ADHD. Remember, the hallmark of ADHD is the foundation of symptoms in childhood and early adolescence that evolve relatively unchanged over the course of time.